It's my pleasure to introduce the moderator of this session, Professor Don Holmes, in our digestive disease section. Don is the director of the Inflammatory Bowel Disease Center here at UCLA.
Yeah. Thank you, Raman, and good morning, everyone. So we finally arrive at IBD, moving from the pancreatico-biliary disorders to inflammatory bowel diseases. And it's my pleasure to introduce this distinguished faculty that helps us out with this session. So it's my great pleasure to welcome Bill Sandborn. Bill has been with Mayo, I think, since 1993 until 2011, and Bill and I go back, I think, from the 90s. The first time that the first patient was actually dosed in Amsterdam with the CA2 molecule, or the anti-TNF that became known as Infliximab. And since then, Bill has actually basically overseen many of the drug development programs that you're about to hear his overview about. After Bill, we'll try to figure out what is the landscape currently, what is the pipeline of drugs that is out there that will reach your practice tomorrow. Then if you pick up one of the biologics that is basically on the shelf today, which is registered, then it's the question of how do you actually follow up with patients, how do you monitor them, and how do you optimize drug therapy. And Christina or Tina Ha will address that in her presentation. Then moving from drug therapy to pouch. Pouch is really still has been a very challenging clinical entity for us in practice, and Jen Choi will help us out there to basically conclude this session with the surgical options in IBD. And surgery in IBD is definitely not a last resort today. It's really the multidisciplinary teamwork that needs to be in place with surgeons. Then instead of case presentations, because there are a lot of questions from the audiences about the new drugs, which one to choose first, or maybe you have other challenges in your clinic at the moment, please use the note cards that you have and hand them down so that at the end of this session we'll focus on the questions that you actually might bring up today, and I'm sure we'll have a lively discussion. Okay, Bill, please come to the floor and tell us about new therapeutic approaches, drugs, worms, and transplantation.
Well, thanks, Don, and the course organizers for inviting me. We think of UCLA as our sort of big brother to the north. And certainly Jennifer and Christina and Jonathan and Don and I share quite a few patients together now, so I'm delighted to be here today. So Dan assigned me this kind of ambitious topic and then told me I needed to say precisely on time, so I'm going to try and cover the topic and do that. Here's the broader pipeline. I won't be able to touch every bit of this, but if you look at some of the high points here, there's low systemic availability steroids, which improve the therapeutic window. There's advances in anti-TNF therapy. The biggest advances really, I think, come around therapeutic drug monitoring, and I'll leave that to Christina to talk about. The big thing that's really coming, it's going to hit your practices in about May or June of this year, is anti-adhesion molecule therapy with the anticipated FDA approval of vedolizumab, so pay careful attention to that section. Chinese herbal medicine for mild to moderate ulcerative colitis, Andrographis paniculata, some anti-interleukin 12 and Janus kinase, and then we'll talk a bit in the last few slides about worms and transplants. So starting with steroids, many of you will have used ileal release budesonide for right colon and ileal Crohn's disease for the last 10 years or so in the US, even longer in Europe. Unlike mesalamine, where it's not so critical where you deliver the drug because it's only partially absorbed where it's released and partially it goes downstream and is absorbed, budesonide is highly lipophilic and it goes in where you deliver it. So the bombing precision with budesonide is much more important than it is for mesalamine. And so ileal-release budesonide, or Entocort, doesn't really work for Crohn's colitis or for ulcerative colitis. So here are trials looking from a US and European trial at MMX budesonide, so a colon delivery system. This is exactly the same delivery system that you're used to seeing with MMX mesalamine or Lialda, but delivering a steroid to the colon. And here the delivery to the colon is important. You can't really interchange ileal release and MMX budesonide. And what you can see is that the budesonide is about 3 times more effective for a tough endpoint of combined clinical and endoscopic remission. There was a comparator arm of ileal release budesonide, which didn't work as well. And there's a comparator arm of mesalamine 2.4 grams, which also didn't work as well. Now, we know that mesalamine works, so what that tells us is that this is a tough endpoint, and in this patient population where a drug that you know works in practice, that the budesonide formulation worked even a bit better. This is something that I think will come in the fall. It's a budesonide foam application. These data were presented at the ACG in October. The IND or the NDA has been filed, and the anticipated approvals around October or so. So 2 clinical trials for 6 weeks using foam. About half of these patients were failing full-dose oral mesalamine, and about half were not on other therapy. So this trial is kind of a mixture of first-line therapy in patients with proctitis or proctosigmoiditis that are not on other therapies, and patients with proctitis or proctosigmoiditis that are failing oral mesalamine. And those patients, very often you might be thinking about systemic steroids or immune suppressives or even biologics in some cases. And here you could capture a good hunk of patients with adding a budesonide foam. So that's something interesting. Here in Southern California, I've learned that marijuana is one of the food groups. I hadn't appreciated that when I lived in Minnesota. I saw probably 3 or 4 cases of cyclic vomiting in 20 years in Minnesota. I make a new case of cyclic vomiting in IBD patients about once a month because there's so much marijuana use. So there's obviously a big hankering amongst our patients for natural therapies. So this is a herb that has been used for millennia in China and Thailand, India. And so a Chinese company, Hutchison Metapharma, took this through a organic extraction process to concentrate the components of the herb. So what you get at GNC is not what we studied. It's a more concentrated version of that, and then tested it in ulcerative colitis, and it's been tested a little in Crohn's as well. So here's a phase 2 study that we published last year looking at 1,200 milligrams a day or 1,800 milligrams a day, and you can see this nice dose response for endpoints of clinical response and clinical remission and mucosal healing for the 1,200 and 1,800 milligram doses compared to placebo. So this was, this Chinese company then partnered with Nestle, the food company, who has a health sciences division, and they're jointly developing this herb for the treatment of ulcerative colitis. It's in phase 3 clinical trials now around the world. Not sure if there's sites in Los Angeles. I think there must be. We're testing this in San Diego. And then there's probably going to be, later in the year, a trial of this in mild to moderate Crohn's disease. So if these data are replicated in phase 3, this could be a really interesting addition to the armamentarium for the earlier phases of treatment. This was a study done in Italy, published in Gastro a couple of years ago, looking at rifaximin delivered to the ileum and colon. Now, you could kind of ask the question, all right, well, rifaximin in general is a non-absorbable antibiotic, so why do you need a delivery system? And I'm still not totally sure I understand the answer to that question, but one of the other things, it's not just the rifaximin that you're used to using, which is a chiral mixture. So I forget which way it goes, but this formulation is more chirally pure, either right or left-handed mixture, and then it's delivered in a concentrated fashion to the distal ileum and colon. And what you could see here was some evidence of benefit for the middle dose. And there is some in vitro data to suggest that if you get the dose too high, that there could be a pro-inflammatory effect, and so there might be a U-shaped dose-response curve, which is sort of what we saw here, an inverted U. So this is getting ready to go into phase 3 trials around the world, especially in the US, so you'll probably start to hear about this much more in the years to come as a treatment for Crohn's disease. Kenyamab was approved last May, so this is a fully human IgG1 sub-Q anti-TNF antibody. Previously had been approved for rheumatologic indications and is now approved for moderate to severe ulcerative colitis. And I'll show you the data behind the approval. So here's the induction trial. The primary endpoint for induction was clinical response, and we compared 200 milligrams at week 0, 100 milligrams at week 2, or 400 and 200, and then looking at response at week 6. And you can see both of the doses looked about the same. So the FDA ended up approving the 200 and then 100 milligram loading dose regimen. Here's the same regimens looking at the endpoints of remission and endoscopy healing, and you can see that across all 3 of these measures, the outcomes looked pretty similar. So the 200, 100 for induction is what was approved by the FDA. Now, just as a frame of reference, for rheumatoid arthritis, the dose is 50 milligrams every 4 weeks. So it looks like they need vastly less drug than our sick ulcerative colitis patients do. And that's kind of a theme that I think Christina will probably talk a little bit about in her therapeutic drug monitoring talk. Then we took the patients who had responded to induction therapy with Kenyamab and re-randomized them to 100 milligrams every 4 weeks, 50 milligrams every 4 weeks, which is the rheumatoid dose, or placebo. And you can see that in general it looked fairly similar, but the p-value for remission was not significant for the 50 milligrams every 4 week dose. And so on that basis, the FDA ended up approving 100 milligrams every 4 weeks as the maintenance dose. I was kind of happy with that because we've ended up on the higher side as opposed to being stuck with trying to dose escalate some of the lower dose patients. So this has turned out to be, quite a nice addition to our armamentarium for UC, along with infliximab and adalimumab. The next bucket has to do, so I kind of think of anti-TNF drugs as putting out the fire. It's a pro-inflammatory cytokine. You can get large amounts of TNF, and anti-TNF antibodies are really targeting knocking out that TNF and trying to put the fire out after the fact. Integrins block trafficking of white cells from the vascular space into the gut. So in a sense, this is more of preventing the fire from happening to begin with, or if there's an established fire, you're sort of starving the fuel to the fire and let it burn out. So once you start lymphocyte blockade, you're going to have a bunch of lymphocytes that are still in the gut driving inflammation, and until you deplete those lymphocytes, and remember lymphocytes live about 90 days, it could take, the putting out the fire might take a while. And that's actually what we sort of see in the clinical trials. You have an induction effect, but the really dramatic effect with this class of drugs seems to be during the maintenance phase. So recall that lymphocyte trafficking, you have integrins on the surface of lymphocytes, and typically these are a dimer of alpha-4 beta-1, which binds with VCAM1. VCAM1 is expressed in the vascular endothelium of cells all over the body, including the brain. And then there's a separate set of integrin dimers, alpha-4 beta-7, which bind with MAdCAM1, and MAdCAM1 is only expressed in the vascular endothelium of the gut. So if you block alpha-4 beta-1 VCAM1, you're blocking lymphocyte trafficking in all tissues in the body, basically. If you block alpha-4 beta-7 MAdCAM1, you are selectively blocking lymphocyte trafficking to the gut. So if, in the way that you think of mesalamine as a topical therapy or a local therapy, MMX budesonide or budesonide foam as a local therapy, well, this is really, if you block alpha-4 beta-7 MAdCAM1, and you can block all those pieces, you can think of this as a gut-selective biologic therapy that ought to be safer because you're leaving lymphocyte traffic in the rest of the body intact. And the reason this is really important, that there's this drug natalizumab or Tysabri that's approved for Crohn's disease but hasn't been used very much because it blocks lymphocyte trafficking everywhere, including the brain, and it puts patients at risk for progressive multifocal leukoencephalopathy, or PML, which is a viral infection of the brain. So the goal of developing more selective drugs was to try and get the benefits of selectively blocking lymphocyte trafficking to the gut, but leave immune surveillance in the brain intact and prevent PML. So the drug that, this drug, and I'll show you the data in just a second, was reviewed for both the indications of ulcerative colitis and Crohn's disease by an FDA advisory panel in December. They recommended that both indications be approved. The PDUFA date is at the end of May. So we're kind of expecting these drugs to come into the clinic in June of this year. So this is a IgG1 antibody targeting alpha-4 beta-7. So here are the data that were published last year in New England from the phase 3 trial. These are induction data, and you can see that vedolizumab was effective for inducing clinical response, clinical remission, and mucosal healing by 6 weeks, so a pretty early endpoint. It's given intravenously, and this was dosed, I think, at 0 and 4 weeks, and then measured at, the endpoint was measured at 6 weeks. If you follow the patients on out to about 10 or 12 weeks, the remission rates get up closer to 50%. And this gets up to what I was telling you earlier, that it takes a while for the resident lymphocytes that were already in the gut before you shut off the trafficking to die off before the fire starts to extinguish itself. Here are the maintenance data. So patients who responded to induction therapy with vedolizumab were re-randomized to 300 milligrams every 4 weeks or every 8 weeks versus placebo. And you can see that both of the dosing regimens were very effective in maintaining a clinical response, clinical remission, mucosal healing, and most importantly, steroid-free remission. So this is quite a nice effect, and I think will be well received by clinicians and patients. These are the data from the Crohn's trial, and the primary endpoint was clinical remission. There was a significant difference. You can see the absolute effect is smaller here, but again, if you follow the patients out for 10 to 12 weeks, the remission rates go up over time. And back in the early 2000s, when we were doing the studies with natalizumab, the less selective anti-alpha-4 beta-1 plus anti-alpha-4 beta-7 antibody, we could see the same thing, that you really didn't get the maximum effect with natalizumab until 12 to 16 weeks. So 6 weeks is a little bit early. There's an effect here, but not as big as probably what would see at a later period in time. And then here are the maintenance data. So amongst the patients who initially responded to vedolizumab for Crohn's, then both every 4-week and every 8-week dosing were beneficial for maintaining response and remission and steroid-free remission. There's some other drugs in this class. Pfizer is developing an anti-MAdCAM1 antibody, so instead of blocking the lymphocytes, you block the target of the lymphocytes in the gut endothelium. Etrolizumab is an anti-beta-7 antibody, and then there's another one, so that's Genentech. Amgen has another one, so there's several under development. And this is just to show some of the early phase data showing benefits with anti-MAdCAM1 antibody at 12 weeks. And then this is anti-beta-7 antibody. These data were presented at DDW this year. Again, you can see a benefit for complete remission compared to placebo over 10 weeks. This is a S1P1 inhibitor. There's a drug that's used now in multiple sclerosis called Gilenya that's pretty widely used, and it basically traps lymphocytes in lymph nodes. So the lymphocytes are there, and if they're there long enough, they'll die, but it traps the egress of lymphocytes from lymph nodes. So you get kind of a decrease systemically in the circulating counts of lymphocytes selectively, and this has been a good therapy for MS. So there's a company called Receptos in San Diego that has another S1P1 inhibitor that they're testing in phase 2 right now in ulcerative colitis. The interesting thing about the Gilenya version of this, the MS version, has a lot of cardiac toxicity. So it can affect the QT interval and QT prolongation. You have to do all kinds of cardiac monitoring. It looks like the drug that's in development in ulcerative colitis is going to have considerably less cardiac side effects. And so it'll be interesting to see what the data look like that over the next year or so. These were the MS data. We don't yet have data in ulcerative colitis. Interleukin-12 and 23, so the drug that's in clinical practice for psoriasis is Kenyamab. It blocks the P40 subunit that is shared by interleukin-12 and 23, and we've been testing this in Crohn's disease. So here are some phase 2A data showing that Kenyamab was more effective than placebo, and it looked like it worked particularly well in patients who had previously received anti-TNF therapy with infliximab. So then we went on to do a phase 2B study where we looked at Kenyamab in a pure population of anti-TNF failure patients, and you can see over 6 to 8 weeks that you had significantly better response rates for Kenyamab as compared to placebo. And then we re-randomized those responding patients to drug or placebo, and here you can see that the patients that continued Kenyamab had better rates of response and remission over about 16 weeks of maintenance therapy than patients who went off the drug. So this drug is also now in phase 3 for Crohn's disease. I suppose the clinical trials will wrap up sometime next year, and then potentially this will come into clinical practice a couple years out. Tofacitinib is an inhibitor of Janus kinases. There are 3 different kinases, JAK1, 2, and 3, that have a variety of anti-cytokine effects. It's orally administered. The drug that is being tested in phase 3 now in ulcerative colitis is Tofacitinib, which blocks JAK1 and JAK3 relatively more than JAK2. This is currently approved for rheumatoid arthritis as Xeljanz, and again is in phase 3 for ulcerative colitis and phase 2 for Crohn's disease. Here are the data in ulcerative colitis. If you focus on the first couple of columns, you can see that in maybe the second row, 10% of patients achieved remission over 8 weeks of therapy on placebo. And when you get up to 10 and 15 milligrams BID, 49 and 41% of patients achieved remission over 8 weeks with this orally administered molecule. And then remission rates, endoscopic remission and the response rates were higher as well. So these are very nice data for an oral molecule in moderate to severe disease, again in phase 3 testing now. The worms, Trichuris, I think at the time that I got assigned this, there was a phase 2 trial in Crohn's disease and a phase 3 trial in Europe in Crohn's disease that hadn't come in yet. So the promise of this was this investigator-initiated study from University of Iowa some years ago suggesting that this might work in ulcerative colitis. And then these were the data reported by Coronado Biosciences that they did a 250-patient trial in Crohn's disease and ended up not seeing an effect in Crohn's. And a similar result was seen by Falk Pharma in a trial in Europe. So I think this has kind of stopped development now for inflammatory bowel disease. And then a mesenchymal stem cell transplant, there's a variety of ways to approach this, and Don, we might talk about this a little bit in the discussion. But basically, so not much controlled data yet, but a lot of observational studies in very difficult to manage patient populations suggest there might be a benefit. Some of these data were done by Don and his group when he was in the Netherlands. And I think we're probably headed towards some better quality RCTs. There's a couple of companies that are really starting to focus on various stem cell strategies, Mesoblast, for instance. Pfizer's partnered with Athersys on a compound. Celgene Cellular Therapeutics has one. So I think we're going to see a number of stem cell products come out of phase 2 in the coming year or two. And then we'll see where it goes from there. But to my mind, this seems like an interesting and promising thing, particularly in California, where there's a big state initiative to fund stem cell research, and it makes sense for us to be looking at this a bit in this state. So I'll stop there, and thank you for your attention.